Hello, everyone, and welcome back to the Lube Tube. This is our very first episode where we're recording obviously audio, but also visual. So if you have a chance, you can step on, I think, YouTube, right? The Lube Tube will be on YouTube. Am I right, Brittany?
Yes. I actually think it'll be on other platforms too. I just don't know how that works. So
okay, well, we're still trying to figure that one out, guys, but we're going to get there. But this is an episode all about the bones. So bones, sweet bone, and we're going to talk about keeping your skeleton happy and healthy. And we're going to have a special guest today, which Brittany and I are really excited about. But mainly what we're going to dig into is how to prevent and treat and kind of just open your eyes to how important our bones are to us as women. And the main things that we're going to really discuss is osteopenia and osteoporosis, and then also versus normal bone, kind of, and what that all looks like. Sound like a plan?
Sounds like a plan. Can we?
I like how you sing everything.
Well, I told you, somebody said that everybody can sing. But again,
we talked about that last time.
Yeah, I don't think
that's a big negative.
Definitely not me. Everybody knows I love some statistics. And when I heard these statistics about osteoporosis, it was a lot. I was kind of blown away.
It's scary, right?
It is scary. So women, us as women, we are 4 times more likely to develop osteoporosis than men. And that is primarily due to the loss of estrogen that we have during menopause. Thanks.
Right.
Thanks, creator.
Yeah. Thanks, ovaries. Thanks, ovaries. Thanks for just like putting out on us. Appreciate that.
Thanks, evolution.
And why does it have to happen so young? We just freaking like stop being able to procreate, and the body's like, you know what? We're just done.
Well, you know what?
Just go.
You know what's actually funny? I heard that we're one of 4 mammals that go through menopause, and that a lot.
I heard that too.
Yeah, I think we listened to the same podcast, and that
probably did.
And that another one was a beluga whale, which I've always been like, I had a weird fascination with beluga whales. So maybe it's because I'm more closely related.
Because you're one with them.
Cute.
Isn't another one giraffe?
I don't remember the other.
I know there was that up.
I know there were like, we're one of 4 mammals that do it. So
I know.
And the reason
is crazy. So when you think about all the mammals on Earth, and there's only 4. Total of 4 that go through menopause. That's crazy.
I know.
Why us?
But the reasoning, if you remember, was that there is that evolution, or in our how we have been able to far surpass how long we're supposed to live. That is why we experience menopause. So basically, they're like, you're actually supposed to die, but y'all figured out how not to die. So this is your punishment. Here,
yeah, this
menopause
is osteoporosis.
Yes. Okay, I got another statistic.
And dry vagina.
Oh God,
dry vagina and your bones don't work.
I know, really. Like they really gave us the big F you. Okay, so 50% of women will also have experience in a fracture before they die. 50%, and these statistics get worse. Okay.
This is the worst.
I know. So our ladies 65 and older that have a hip fracture, even with surgical repair, there's 20% mortality rate within the first year. And let's say
first year.
Yeah, first year. And let's say they like, you know what, no surgical intervention. This person maybe isn't strong enough to have a surgery. Their mortality rate is 70%.
Oh my gosh.
Wild.
That is insane, right? Like that is insane. And I would think that it would come down to the increased risk of, you're just not mobile anymore, right? Your mobility goes down after a fracture, especially if you're 65 and up and you don't have that bone growth happening anymore and you don't have the estrogen to help heal. But I guess also it comes down to, since you are basically just kind of more sedentary, you are at increased risk for getting high blood pressure, increased risk for gaining weight, more, getting obesity, which then leads to increased risk for DVTs, blood clots, pulmonary embolisms. So I guess that's kind of where all of that kind of starts diving. But man, that's an awful statistic, right? So if there's anything that makes me want to take care of my bones now when I'm in my 40s, it's those statistics.
I know this was supposed to be very impactful. So I hope everyone that's listening is like, damn, not me, not going to be me.
I know. I know. But I think that it's great that we do this episode because guess what? It could be you, right? And the only way for us to obviously prevent that are some of the things that not just you and I are going to share, but our guest is going to share. She's got some really great information. Some things that I know when we were chatting with her a couple weeks ago, she had some information that I had never even heard. So I think she's going to offer our listeners, as well as you and I, some really good education.
Absolutely. So let's talk a little bit about the difference between osteopenia and osteoporosis.
Mm-hmm.
Do you want to go?
So, yeah. So I just want to talk. Look, I'm so bad. Like, let me steal the show. You're like, Jeanette, do you want to talk? Because I could see you want to talk.
Yeah, you were itching. Okay. You were itching for that one. Okay, go.
Okay, so the two main differences, and I think we talked about it going back to that honeycomb, right? So osteopenia is the beginning of the breakdown, and where osteoporosis is the severe breakdown, the severe bone loss that has already occurred. My whole goal would be to catch this in a patient prior to osteopenia, right? Because can we get back to normal bone from osteopenia? Sure, absolutely. There are ways to do that. But my goal would be to catch you with a bone density scan way prior to even osteopenia or the breakdown, right? And so osteopenia then leads to osteoporosis if it's not taken care of accordingly, right? So what does that mean? That means getting that bone health back up with vitamin D, like we talked about in the last episode. Also talking about calcium, weight-bearing exercise, all those things. And we're going to really get into those with this episode. But really, the whole goal would be to catch you before there, right? With normal bone density.
Right. And there's certain risk factors. So there's some that we can control and others that we cannot. We can't control our age. We can't control our gender, genetics. What we can control is not smoking. I mean, smoking is so interesting to me, mostly for people, I guess, kind of in like our age group, because we know what it does. We know all the terrible things it does. And I still see people our age and younger, and man, it gets me. It really does.
Yeah. And I feel like there's this whole new, like, hey, I'm vaping. So it's got to be better for me. Well, I think to an extent, yes, right? Like cigarettes are going to have all the carcinogens in it, and it's going to have everything else, all the additives that also cause and wreak havoc on our bodies. But you're still inhaling something that you're not supposed to inhale. Like vaping is literally a vaporized solution, right? Lungs aren't supposed to have solutions in them, right? We're not supposed to inhale a vaporized liquid because guess what, right? That's when we get other things like infections. And fungal infections is obviously a big one that I have read about in journals about how people that are now vaping a lot are ending up with these superimposed fungal infections that are really hard to treat, right? Long-term treatment. And I know that that's not what we're talking about today.
I digress.
But it does scare me. I know. Well, it scares me for like the super younger generation,
well, yeah, because
right?
I feel
like my kids' age.
Yeah,
their vaping is all in their face, just like cigarettes were in our face, right? And they're trying to pass it off as this healthier version, and I'm not convinced.
No, I think there was, I don't know if this was a Texas thing or a like United States thing, but I know that you can no longer, in all the places that you cannot smoke cigarettes, you can no longer vape either.
Oh, so, okay. Yeah,
I don't remember exactly. I always know about like half of a.
Half of the half.
Yes,
which I love.
No, a little about a lot,
enough to make me go. I know.
Enough to go Google and be like, oh yes, she was right, but XYZ. Yeah.
But I'm going to write in and tell her how wrong she really was.
Okay, back to a few things that we can actually control that can contribute to good bone health. Our nutrition as well.
Right.
Physical activity, which that's a hard one for a lot of people. Alcohol intake. Dry January.
Are you doing a dry January?
No, I don't feel like I dry January would be very easy for me because I'm mostly dry. January.
Oh, well, look at you. I can fix up your dryness. Oh, we're talking about alcohol?
Big yikes, Janet. Jeez.
Okay, did you see how Starbucks spelt my name the other day? Did I send it to you? Geanette.
I mean, phonetics, obviously.
It's not Janet. So there's that.
Okay. Hey, I think it's time, as I look at a little outline in front of me. It's time to bring Christina into this conversation. So,
why don't you introduce her?
Without further ado.
All right, everyone, without further ado, this is Christina Yazdani. She's a physician assistant as well, and she received her Bachelor of Science degree in neuroscience from Tulane University in 2008. I know, right? Super smart. Followed by her Master of Science degree in physician assistant studies from Baylor College of Medicine in 2014. She worked in UT Physicians Orthopedic Joint Replacement Service in 2015. Afterwards, she joined the orthopedic trauma team in 2017 as part of the Bone Health Clinic. Yazdani is certified by the National Commission on Certification of the Physician Assistants, is an active member of the National Osteoporosis Foundation and the International Society for Clinical Densitometry. She also became a certified clinical densitometrist in 2019. That is a really hard word to say.
Well, and I want you to explain what that is. Can you explain what that is exactly?
Yes. Go for it, Christina.
Well, thanks for having me, guys. So a densitometrist is someone who's been trained beyond whether you've gone to PA school, nurse practitioner, med school. It's someone who's received extra training on how to interpret bone density scans. So you pass a test for that and keep up with your CMEs just like you would your license. And it just gives you some extra insight into reading bone density scans.
Okay.
So what are their recommendations on, like, as far as when to start somebody getting a bone density scan? Like at what age?
So this, I have a little, I don't know, soapbox about it.
Oh, we love soapboxes.
The current USP STF guidelines say that all women at the age of 65 and all men at the age of 70 should get a bone density screening. Anybody that does bone density or osteoporosis or bone health in any way really tends to think that's a bit too late, especially when we're talking about women. So, if we go through menopause around age 50-ish, we know that we're going to lose a good 10 or 12% of our bone strength within those first 5 years of menopause. So it seems a little silly to be waiting, maybe 10 or 15 years or more out from menopause before we're even deciding to check a bone density scan. I think it would be great if everyone could get just a baseline bone density scan at menopause, just to see where you're starting from. But the guidelines currently are 65 for women, 70 for men.
That is so much older than I do in my clinic. And I agree, just like you said, just the complete lack of estrogen or the loss of estrogen is going to put us at greater risk. So why wouldn't we get a baseline sooner than 65 years old for these ladies?
Yeah. And honestly, you can get one sooner if you have risk factors. And almost everybody I see has a risk factor. It can be things like family history of bone loss, if you went through early menopause, if you're on certain medications like prednisone or any steroids long term. We think of women who are on certain medications like aromatase inhibitors for breast cancer treatment. Most commonly, people taking these PPIs for acid reflux. And then a lot of people are on SSRIs for management of depression, anxiety, other mental health conditions. So any of these things could get you an earlier screening covered by insurance. If you've had a previous fracture as an adult, there's lots of things that can get you covered sooner. So I don't think yet I found somebody where I just did not have a reason to get them a screening by the time they've come to my office.
Oh, that's good. And tell me about it, like a bone density scan. Are these painful? Are they difficult? Are they long tests? Is it something that has to be prepared for?
There's a little preparation. Most places that do bone density scans want you to hold any calcium supplements or calcium containing supplements like a multivitamin for 24 to 48 hours beforehand.
Mhm.
Sometimes, since the bone density scan will pick up your spine, sometimes they will notice or they can see that calcium tablet or that calcium chew sitting in your stomach if you took it right
Huh,
before, and
that's
it can
funny.
actually create an artifact and then falsely influence the screening for the spine. So that's really the only prep, but it's a very easy scan. You basically lay on your back on what looks like an X-ray table, so it's not in a tube like an MRI. So
Mhm.
there's no claustrophobia concerns. And there's this arm that's over the top of you. It kind of looks like it's scanning you from head to toe, but it's scanning your lower back, both your hips, and sometimes they'll even do your forearm. And the whole thing is quick. It only takes about 10 or 15 minutes. There's very, very little radiation that actually occurs with a bone density scan. In fact, most places don't even put it in, the special rooms where they have
Oh,
the
okay.
I forget what it is, but the lining that you have to put X-ray
Uh-huh.
machines and things in, you can just put it in a standard room because it's so little radiation. So it's
Oh,
really a
that's really
very
helpful.
safe, yeah, very safe, very
Mhm.
quick, very painless exam. So I typically don't have problem with people actually doing the exam.
So,
Okay.
when we're talking about vitamin D, what is the level that you would prefer your patients be at? Because
Yeah,
I know
so
that's
there's
historically a huge issue in our clinic when we have people come in and their vitamin D is at 12 and they're happy about it.
yes. Yeah, or
That's
they're
great.
usually just have no idea. So
Right,
Right.
right, exactly.
there's a lot of debate about this actually. So most reference ranges will kind of start at 30 as the lower limit of normal. There's some data that supports the lower limit maybe being 20. In general, I think the vitamin D assay that you get, it's most of them have about a 10-point fluctuation either way. So I typically try and aim for a level of 40 to 60, just thinking that if you're at 40, it may be a 30. It's just the lab test itself.
Mhm.
If you're a 60, you may actually be a 70, and that's okay. The upper limit of normal is 100, so we're still well within the normal range. And I
Mhm.
have found some people that even if their level is a 30, they just seem to get better response from our treatments, or some of their other labs may just reflect a better balance if we can get them up to 40 to 60. So that's what I typically shoot for. But I think everyone would agree, if you're above 20, that's the bare minimum. A lot of people would also say 30 is a bare minimum.
Mm.
Okay.
But if you're a
So,
12, unanimously, you're low.
right? So, our recent episode, we talked about supplementation, and the big ones that we went into were vitamin D and calcium. And as far as like prevention, I know in our clinic we talk a whole lot about hormone replacement therapy. We talk about vitamin D, but are there some preventative strategies that you kind of go over with your patients to basically get them before they become osteopenic or osteoporotic?
In terms of like supplements or
Yeah,
all
supplements
prevention.
or even really all of it, like, as far as recommendations.
Yeah. So my ideal preventative person is someone who is perimenopausal. I
Mhm.
always say it's easier to prevent than to try and build your bone back up, by the time you're at osteoporosis. So if we can get you early, get a bone density scan that just shows a little bit of bone loss, then hormone replacement can definitely help prevent some of that loss. We can also talk about exercise. So the best types of exercise are going to be weight bearing things, which can be as simple as walking. Muscle strengthening or resistance based exercises are really very key, for many reasons, but for bones, I always tell my patients, if you're strengthening your muscles, you're strengthening your bones. So I don't care necessarily whether it's free weights or weight machines or bands, or you're doing classes and doing body weight stuff. It really doesn't matter as long as it's something that you can kind of stick to consistently. Um, and it's you doing resistance. That's the best thing you can do for your bones.
What
There's
about,
also some good.
oh, sorry.
Go ahead.
I just wanted to, sorry, I completely interrupted you, but
That's
weighted
okay.
vests are like this hot
Yeah, that's the
thing
whole
right
new
now.
thing.
It
Mhm.
is. It is. Like I said, the majority of people I get already
Yeah.
have some bone
Right.
loss. And so kind of putting added weight on you, it's not going to provide any better benefit than you just walking with your own body weight.
Hmm.
And you still need to do the strengthening exercises. So I am typically discouraging or not encouraging people to go out and buy weighted vests. We
Hmm.
really worry more about how that can affect your spine. If you've already got bone loss, and I think about the
Sure.
person who may kind of get thrown off, that's not your
Mhm.
normal body habitus. So if you're going to twist or bend or something like that, it's going to be putting more force on your spine. And if you're twisting or flexing or extending your spine, it's going to be more prone to fracturing. So I just think you're better off without a weighted vest.
That's
Oh,
so helpful because like Brittany said, it is, I'm sure all over social media, like, this is the way to do it. This is the way to prevent bone loss. And I can see it in maybe a younger girl that doesn't have a risk for compression fractures of the spine. But
Mhm.
the older lady who's never really exercised much just goes out and buys a weighted vest. I feel like that could probably be a little bit more of a bad thing for her.
Yeah, it's the same thing I get, like, if someone comes into me and their preference is running or, whether it's, jogging, marathons, things like that. Running is a good exercise. We do have data that shows that impact exercise is actually really good for bones. But if you're thinking of, I've never exercised before, what's a good activity? I'm probably not going to recommend an impact activity. I'd rather you walk and do the muscle training, muscle strengthening. You're going to get more out of it, and it's going to be less risk. Kind of like people that do yoga, you might be really flexible. So telling one person maybe you shouldn't bend down and touch your toes would be a good thing, but if someone's
Mhm.
maybe done yoga their whole life, and that's, absolutely no
It's
problem
patient
for them.
dependent.
Yeah.
Mhm.
So it's about listening to your body and making sure that
Mhm.
you're not um, going beyond what your body is capable of at that moment. But at the
Gotcha.
same time, I have at least one patient, two patients that are actually bodybuilders. And so they're out there lifting huge amounts of weight. So it's
Right.
not that you can't take heavy weight. It's just you have to know where you're starting from and then build up safely and appropriately. So, resistance
Okay.
training balance is another big thing I talk about prevention wise. Obviously, if we're not falling, we're less likely to break bones. So, balance declines as we all get older. So, you actually have to practice it if you want to maintain it. Um, so balance. What else about prevention? Oh, nutrition we talk about a lot. So supplements is part of that. Calcium and vitamin D are the big ones that people think of. There's a lot of talk too about vitamin K lately, magnesium, all sorts of different supplements, collagen that people come up with. I would say
uh-huh.
for all of those except calcium and vitamin D, the data is a little hit or miss. So I don't really recommend those for people to take. However, if someone wants to try it, I don't see much that's saying it's harmful for bones. So I kind of
Right.
tell people if you want to, go for it, but it's not going to replace the other recommendations that we're talking about.
So when you get these bone density scans back and one of them says, somebody that's significantly osteopenic, which is the beginning of that breakdown, um, and they're leaning more towards osteoporotic, at what point do you recommend treatment? Like
So
with
that's a
a
hard
pharmaceutical?
question. Yeah.
Sorry.
So part of it, no, it's a good question because the diagnosis of osteoporosis
Mhm.
it's not just one thing. A lot of people think, hey, I've had my bone density scan. My T score says I'm a minus 2.5. That's osteoporosis, which it is. But you can also have a T-score of maybe a -2. And if you've had a fracture before, say last year you tripped and fell and broke your wrist, that bumps you up a level. So that's also a
Mhm.
diagnosis of osteoporosis. I also like to use this risk assessment calculator. It's called FRAX,
Mhm.
FRAX. And this is
Mhm.
great because anybody can do this. It's online if you just Google FRAX. There's a free version out there, but it plugs in all sorts of different things about you: age, height, and weight. If you've broken bones before, you could input your bone density score if you've had one. And it basically is trying to predict your risk of breaking a bone over the next 10 years. And so it'll give you your risk of breaking any bone over the next 10 years, and it'll give you your risk of breaking a hip specifically over the next 10 years. And if those come back elevated, which risk of any bone breaking over 20% and risk of hip breaking over 3%, if that comes back elevated, you can also make a diagnosis of osteoporosis too. So
Okay.
there's many ways to diagnose osteoporosis. And so if any of those actually are there, if someone I can say, no, you're actually osteoporotic, then that's a reason to start treatment. If you are truly osteopenic, then we may want to, see what else we can work on. Are your supplements correct? Are your levels all okay? Are you doing exercise? I do a really extensive workup for other causes of bone loss too. So I always tell people we really want to make sure there's not something else going on besides this hormone loss that comes with menopause that needs to be addressed first, rather than immediately jumping to an osteoporosis medication.
Yeah, so and with that, you're talking about maybe like the parathyroid, possibly even a thyroid condition, right?
Yeah, thyroid,
Mhm.
parathyroid. I've even started screening things like for celiac disease.
Mhm.
I've diagnosed like multiple myeloma,
Oh,
other
wow.
cancers.
Mhm.
Just stuff that you may not think of in someone that
Mhm.
looks healthy that walks in, but if they have these low bone density scores, you just kind of have to think, well, what else could be going on here?
Sure.
And then we also find rare bone diseases. You think people would have had that figured out by the time they're adults or even middle aged or elderly, but sometimes they just kind of think things that they're experiencing are normal, and when you start really digging and asking questions, you find out they've got some other things going on. And so, again, it's always important to make sure that what you're treating is truly postmenopausal bone loss.
Mhm.
Because if it's not, obviously you want to address what's really going on.
Dr. Google usually provides people with lots of information.
Yeah.
And so I can only imagine what people walk in to your clinic with. Because I mean, we get
Oh,
a
I
very
can only
small
imagine.
percentage of that in regards to
Um,
vitamin D levels. Because we'll say your vitamin D is low. And they're like, I don't know how. I'm in the sun. I'm walking.
Oh, yeah.
you know what
Yes.
I tell
Everybody
people?
thinks if they're in the sun, they're fine.
They are. And I usually tell them, and it's usually an older person, right? And I think, well, but are you like naked? Are you in a bathing suit? Because like, how much skin are we exposing here? If you're going out, your face, maybe your forearms, maybe some shorts in the summertime, I mean, you're really not getting that much skin exposure. If you're wearing sunscreen, you're blocking that ability to make the vitamin D. And we're probably, at least in Texas, not out in the sun that long because most of the time it's too hot.
Right.
Right.
I think people don't really realize that you're not getting the amount of vitamin D that we should get in order to keep those
Mhm.
levels normal. And the thing is, it's not really fortified or found in a bunch of our foods. So it's kind of hard to make it up diet wise, which is why so many people end up on vitamin D supplements.
Okay.
Right.
So when we're talking about what you do treatment wise, I'm a little naive from just being educated with, not that PA school was great, but it's not my specialty. So I immediately think bisphosphonates. That's where I go. Um, I know there's a lot more than that.
Yeah, so bisphosphonates are kind of the staple that people think of. And, I would agree PA school is great, but I didn't learn any of this in PA school. I mean, I think I
Right.
learned bone density scans minus 2.5 osteoporosis. Like
Exactly.
that was
Right.
it.
Yes.
So the bisphosphonates came out in the 90s. So they're kind of the oldest things that we really still use. But kind of starting in 2000, we did get some other medications out there. So I always tell people, your bones, they're kind of like skin. You're always sloughing off dead skin. You're making new skin. This is happening all the time. Your bones are always making new bone and breaking down old bone all the time. And so it typically happens after menopause is we start to break down bone faster than we can make it. So it's really this imbalance that leads to the bone loss. And so our medications are designed to affect that balance one way or another. So we're either trying to slow bone breakdown or we're trying to increase bone formation. So those bisphosphonates slow bone breakdown. And they do a pretty good job. There's lots of different kinds. There's the pills, which can vary from daily, weekly, monthly. There's also IV versions that typically can be done once a year. That's the most common one now. And then there's medications that continue to slow bone breakdown, but they work differently than the bisphosphonates. So denosumab or Prolia is the most common one that's been out since the early 2000s. We also have the ones that increase bone formation. Those also came out in the early 2000s. So Forteo, teriparatide, and then there's Timlos, which is basically came out as a competitor to those in 2017. And then our latest medication, Evenity, that one came out in 2019, and it's actually dual function. So it increases bone formation while also slowing down bone breakdown. So that's kind of the newer stuff that's going on. And so it's kind of up to the individual patient when we kind of go over everything, really figuring out what's going to be the best for them. I would say to me, one of the most impactful things that have come out in terms of bone health is the emphasis now on proper sequencing of medications. So, insurance companies kind of like us to do step therapy, where you have to start with the cheapest thing first
The
Oh,
and
worst.
yes.
least effective,
Mm.
right? And if it doesn't
Right.
work, only then we'll get you the better stuff. But we've got
Mhm.
some really good studies coming out showing that if you're starting with one of these anabolic agents, these bone forming agents first, that not only are you going to get a bigger response to them, but over the long term, you're going to have overall bigger improvements in bone density and likely shorter time on overall therapy. And so, a lot of my patients don't want to be on medication forever, which I totally understand. And so, if we can start with something that may seem a little bit more aggressive, overall, we'll likely spend less time on medications. And the insurance companies, we're hoping to kind of convince them that that means less money overall. Because if we're
Right.
doing a better job and spending less time on medication, that should be good for everybody.
For sure. That was so helpful.
Oh, good.
Yes.
I know.
Brittany is
I
mad at insurance right now.
Oh, that's my
I'm
daily
still
life.
stuck
I
on it.
mean,
Yeah.
prior authorizations,
Oh my God.
appeals.
I can only imagine
Ugh,
like that. The new medication, I'm sure that is hell to get. I can only imagine.
yeah.
Yeah.
I've got a pretty strongly worded appeal letter that I usually use
I
as
like
my
it. I
template
like
and
it.
go from there. So I have to say I've got pretty good uh, approval ratings
Oh,
in terms of or success ratings, I should say, in terms of getting things approved. So
yeah.
That's awesome.
Well, great. Is
All right,
there
well, I'm
any
just gonna send you all my osteoporosis patients.
do it. Tell them to drive on over.
I'm gonna need you to drive all the way to Houston for this
Yeah.
medication.
I wanted to ask you though before we let you go. Is there anything additional that any pearls or anything that you feel people should know that you haven't already said? I mean, you've covered a lot.
Yeah, I think most people that come in, their biggest concern is what they've heard about side effects, potential side effects. And a lot of this, people don't even kind of realize where this comes from, but back in 2010 was when they figured out you really can't be on these bisphosphonates forever. They started
Mhm.
seeing these risks of atypical femur fractures, which is a certain type of femur fracture, and
Mhm.
osteonecrosis of the jaw, which is essentially death of the jawbone, on people taking bisphosphonates for long periods of time. And this is typically more than 5 years. So people that are on them for 10 or 15 years straight. And when they came out, we didn't know this, and so people just kind of started someone on it and then kept refilling it and didn't really think twice about how long they were on it. And so there was a lot of attention. They got these warnings, placed on them, and I think a lot of people don't have the context for it. So people come in thinking, "Oh, I'm going to start this." I just saw a man on Monday who said, "I heard you take these medications, your jaw is going to fall off your face." And I said, "Well, I don't think very many people would take these medications if it meant your jaw fell off your face, down the road." So it is kind of putting, like, we are not afraid to have conversations about side effects. So I don't mind when someone comes to me with a concern about it. We can talk through it. The newer medications do tend to be different. And I think usually once people can talk through what their side effect concerns are, and we can really give how common is this really? What does this mean for you? What's your risk? Then we can work through some of those fears and get people on a good treatment plan. So I kind of say, yes, there's always a risk in everything you do, and there's a huge risk in not doing anything either. So
For sure.
our job is to give you the information, tell you what's out there, answer any questions, and then let you make the decision as to what's best for your body.
Perfect. Well,
Jeanette,
thank you so much,
are you
Christina.
feeling okay over there? Do you
Me?
how are
I
you
think
feeling
she's
about your
doing
vitamin
so
D?
My vitamin D is great. How's your vitamin D?
I
Mine's
have
phenomenal. I just got it checked actually. So I
Well,
was
thank you
like,
very much. How's yours, Brittany?
I don't remember the last time I checked it, but I did start retaking my vitamin D. There was a slight I ran out.
Lapse.
Yeah, a little lapse. I ran out, but I'm back on it. So
Good job.
I
I
know.
just started taking this calcium supplement. So I kind of decided I've been on like a dairy free kick. And so I was like, you know what? I should
Ah.
probably start taking some calcium because I'm probably not getting enough. And so there's these chocolates out there called
Ooh.
Adora.
Mhm.
Adora. You can find them at Whole Foods, is where I find them. But they're like a
Mhm.
chocolate coin, and they come in milk chocolate or dark chocolate, and it tastes just like a piece of chocolate. Like, it does not taste like a vitamin
I would be
whatsoever.
so constipated because I would just sit there and eat the whole dang thing.
Mhm. Oh, yeah. Yeah. But 2 chocolates, each chocolate is 600 milligrams of calcium. So technically, if you're
Perfect.
over 50, you take 2 chocolates a day, and that's your recommended dose of calcium. So,
I love it.
Interesting. I love
mhm.
that too. Okay. All right. Well, thank you so much, Christina. This has been
Yes.
wonderful.
Yes, thank you.
We both definitely learned some things, that's for sure.
Oh, good.
For
I
sure.
mean, I love bone health. It's my passion.
I know we
So
love that.
if I can get
Absolutely.
everyone to get their bone density scans at menopause, then,
Well,
that's a
I will
win.
work on that part for you.
Yeah.
At least in my clinic.
Okay, Christina, I there's literally a reason that she is a what was that word she said?
Densitometrist.
My
Densitome
gosh.
den
Then no, you said it
densito I'm
right.
holy s I said it right?
Yeah.
Densitometrist. Pretty
Yes.
awesome. She's really smart.
I know. We love smart though. We do.
I love smart. I mean, geez, neuroscience degree,
I
it's pretty
know.
cool.
That is cool. Um, so guess what time it is?
I'm gonna guess. Ready? Slippery solutions with B&J.
Notice I did not even try and do that with you because I know better.
It makes me laugh every time because I'm so terrible.
I have big news. I have big news for you. I have big news for everyone listening.
Mhm. Oh. Oh my gosh, did she write you back?
We have an update.
Oh, we have an update.
You know what's really funny? Before I say this, I still don't know this person's name. I know nothing. They like nothing. It was again another anonymous one, but
Okay.
I feel like it's only right that we do it. It's actually a longer one, so just like bear with me.
Okay. Well, for our listeners, let's recap.
Oh yes, I'm so
right.
sorry. That's a good idea.
There was this listener that wrote in, and she had been with her boyfriend for 4 years, and they had a good relationship, but they ended up breaking it off for a little bit. And during that time, she ended up having sex with a woman. And she found it to be extremely great. And she was super comfortable. And then they obviously it was a one night, have fun, forget about it, but she hasn't forgot about it. And now she's back with this boyfriend and she doesn't know how to go forward because she keeps thinking about how great that sex was. And she asked us if she should talk to her boyfriend about it or she should just let it go or what we thought. So here we are with an update.
Hey, ladies. Thanks for all the advice. I decided to confess everything. I decided to confess everything to my boyfriend. Initially,
good. Okay.
He freaked the F out. But the more we talked about it, the more understanding he became. Plot twist.
Okay. Ready.
He eventually admitted he too strayed during our breakup time.
Stop. Stop it.
I was initially shocked, but then had an epiphany. We've both grown out of this relationship. Oh.
Okay.
It's not over. Hold on. I'm not done reading. So I ended things and cannot begin to explain how much weight has been lifted off my shoulders. Thank you guys for giving me the courage to move forward. I'm not sure if females or men are in my future, but regardless, I'm fucking excited.
Oh my God. You go, girl.
Honestly, I mean, I was feel like I wanted to support her in any way if she wanted to stay with this man, but
sure,
it seemed boring. Like it didn't seem like there was any
well,
fire to their relationship. You know,
she described it as boring, right? She was like, it just wasn't as good as that was. But wait, can we talk about him straying?
Oh my gosh, I know. But that just goes to show I think they both were like, this has been fun, but like if they could do it that quickly afterwards, I don't know.
Yeah.
I guess some people
it wasn't meant to be.
Yeah, it wasn't meant to be. But we're proud of you, whoever you are.
I'm so proud of you. That is awesome. Congratulations.
Yes, and thank you for the update. This is going to make a lot of people happy. We actually got a lot of feedback from people wanting to know what was going on here.
Yes.
So.
Can we just say how much like everybody was like, I can't wait to hear the update. I really hope she writes back. And the fact that you wrote us back, like it makes me so happy that other people are going to hear the end of this.
Yes, it's a beautiful thing. Oh, okay.
Man. Let's recap what we learned today.
Yes, let's do it.
What we learned today. So we talked about osteopenia, we talked about osteoporosis, we talked about the prevention, which includes supplements and hormone replacement therapy and weight-bearing exercise and kind of everything that we have to do in order to keep our bones strong. And we talked about like tests that we do, which is a bone density scan. That bone density scan, although recommended, is 65 years old or 70 for males. Christina actually recommends doing it when we hit menopause because that is like a baseline before we start losing that estrogen completely. So I think that's a great idea. And so mentioning that to your provider would be obviously very helpful. If you already are postmenopausal and you haven't had a bone density scan, you need to ask for one. So ask for one, okay? Because your provider might not be thinking about that. You know, there's some gynecologists who don't order them, and that's more of a primary care thing or an endocrinology thing or a rheumatology thing. So it really just depends on what your provider's comfort level is. So it needs to be ordered no matter what by whoever, right? And then the treatment, right? So vitamin D, calcium, weight-bearing exercises are all really good things to help strengthen the bone. But sometimes when you reach that osteoporosis stage where the bone is completely gone or really, really lost its density, then at that point, you're going to need different medications. And there's the bisphosphonates, which are basically the OGs of osteoporosis. But since then, in better science, we've gotten better options, which includes some infusions or injections or even some pills. So I think these are great conversation starters for for us and for also for our listeners, but things that they can bring up to their provider. So
Definitely.
great episode.
A great episode and a friendly reminder to everyone. Do not let insurance dictate how you receive treatment. Fight for your right.
You gotta fight for the right.
Support. Took the words right out of my mouth. Thank you.
I knew I did.
Yeah.
You're welcome.
Mm-hmm.
All right. Well, thank you, Brittany. This has been lovely.
Jeanette, as always, it's been a pleasure.
Mm-hmm.
And
pleasure.
Can't wait to talk to you so soon.
Yeah, like in 5 minutes. All right. Bye.
Bye.
The information provided in this podcast is for general informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.